The following podcast is part of a certified educational activity titled An Expert Analysis of New Data for Uncontrolled Persistent Asthma Treatments, Clinical Updates from Paris. Access the entire activity and complete the post-test at www.peerview.com/GGG. Downloadable slides and practice aids are also available.
Hello, this is Dr. Mario Castro from Washington University in St. Louis, Missouri. Welcome to this educational activity on emerging data on asthma phenotypes and treatment from the European Respiratory Society International Congress in Paris that recently happened. In severe asthma, patients frequently do not obtain adequate disease control using bronchodilators and inhaled steroids. So current treatment often comes with side effects which really lead to poor quality of life and high healthcare burden. These patients are quite disabled sometimes from their disease. Therefore, it's an urgent need for newer asthma therapies that have fewer side effects for our patients. With asthma drug development increasingly focusing on specific asthma disease phenotypes, new treatment options are becoming available to manage this severe disease, and we really need to become familiar with the management of this as specialists. So the presentation of data from trials optimizing asthma treatment, along with these new data on treatments for severe asthma, were the focus at this recent European Respiratory Society meeting in Paris. And I'm going to present some of those studies for you today. First, let's talk about the PROXIMA study. The PROXIMA study was evaluating Omalizumab, its add-on treatment, in our patients with uncontrolled severe allergic asthma or atopic asthma. So it's really in this highly selected population, typically with that IgE level 30 to 700. While the efficacy of Omalizumab has been proven in this patient population before with moderate to severe persistent asthma, there are a few studies that suggest that treated patients may differ in their extent of the response. And this is really due to the heterogeneity of that allergic severe asthma. Now previously, Richaud et al. Reported on galactin-3, or GAL3 as it's referred to, as a possible biomarker associated with airway remodeling. And this was reported in response to Omalizumab treatment at 12 and 36 months after treatment. Now, for those that are unfamiliar with this biomarker, GAL3, it is an IgE binding protein, and current evidence supports its role as an important regulator of inflammatory cell infiltration, activation, and clearance. Now, Dr. Ana Maria Richaud and her colleagues presented these findings now at the ERS Congress in Paris. Now, this was an exploratory analysis from that study, the PROXIMA study, which was designed to really look at biomarkers, in particular GAL3, as measured in the plasma, as a predictive biomarker for response to Omalizumab in these patients with severe allergic asthma. Now, to overview the study, there were 365 patients that were enrolled in this study. And of those patients, 130 were enrolled in a longitudinal study. Of these 130 patients, 58 were enrolled in a sub-study, and 44 of those patients, or about 3 out of 4 patients, completed the study and were considered in this analysis that was presented at ERS. After 12 months of treatment with Omalizumab, 123 patients then were categorized based on their response to this treatment, Omalizumab. And we defined them in 3 different ways: as a clinical responder, a functional responder, or a super responder. So let's talk about how that response was defined. So clinical response was defined as improved asthma control, as reflected by the Asthma Control Questionnaire score going down to less than 1. And truly that defines a well-controlled patient. In addition, they had to have a reduction in the number of exacerbations compared to their previous year. Now, a second responder was called a functional responder, and this group only had improvement in lung function by 100 mLs change in their FEV1 after treatment for 1 year compared to their baseline value. Now, we define the super responders as those patients that had not only that clinical response, improvement in asthma control, reduction in exacerbations, but also showed an improvement in lung function. So those were our super responders. Now let's go over the results. In the PROXIMA study, there was a significant difference, statistically significant difference in baseline plasma Gal3 levels between the responders and the non-responders. However, this was only observed in that functional responder group, the group that we were referring to, that improvement in lung function. So when we look at this analysis, we found that there were higher plasma Gal3 levels observed in those patients that improved their lung function versus those patients that had a worsening or stable FEV1. Now, these changes in lung function were relatively small differences between the groups. So in conclusion, from the PROXIMA study, that this biomarker substudy that was presented at ERS, we find that the use of plasma Gal3 as a predictive biomarker to stratify responders, super responders, and functional responders would be potentially helpful. And ideally, this would be something that could be very attractive to us clinically, and that we could measure it in the plasma. These results indicate that the level of Gal3 can be a predictor really for improvement in lung function in response to Omalizumab. And as noted in the results that we just discussed, we did not see those findings true for improvement in asthma control. However, these are retrospective analysis at this point and definitely exploratory, and a prospective trial is needed to really evaluate this prospectively as a biomarker for severe allergic asthma. Now let's go on to talk about another study, which is quite important because it was really addressing a key step in the GINA guidelines. For those that are familiar with GINA, that's the Global Initiative for Asthma, and it's really the world guidelines for the management of asthma that's kept up to date and has been just updated this past year in 2018. Now, in the GINA guidelines, medium dose and high dose inhaled corticosteroids are recommended as preferred treatments in those patients that are at GINA step 4. Now keep in mind, when you're talking about GINA step 4, that's in patients with that medium dose to high dose inhaled corticosteroid. And when you go to GINA step 4, that's when you're talking about patients on high dose inhaled steroids and you're considering add-on therapy with biologic or chronic oral corticosteroids. So let's focus on that patient in that step 4. In clinical practice, we don't really understand the response to medium dose inhaled corticosteroids plus a long-acting bronchodilator versus high dose inhaled corticosteroids and long-acting bronchodilators, and how does that really impact those changes in our add-on therapy? How does that impact their outcomes? So in the data that we're going to present, we're going to talk about those two groups of patients, those medium dose inhaled corticosteroids plus a controller, long-acting controller, and also those on high dose inhaled corticosteroids plus a long-acting controller. Studies have demonstrated that lack of adherence to these therapies which we prescribe our patients can really reduce the efficacy of that treatment and increase their risk for future exacerbations. So let's understand a little bit better how we could optimally control our patients' inhaled corticosteroid long-acting bronchodilator therapy so that we can approach our patients better with a much better kind of targeted treatment approach in these patients when we're talking about that step 4 in the GINA guidelines. Now in that step 4 GINA guidelines, it recommends the addition of one or more controllers. These are things such as a long-acting bronchodilator, a long-acting muscarinic antagonist, such as what we refer to as a LAMA, or it could also be with a leukotriene receptor antagonist, what we refer to as LTRA. Certainly in some patients still required oral corticosteroid burst in those patients that remain uncontrolled despite this add-on therapy. However, there's really limited data on how we're going to select these controllers in these step 4 patients that are not responding to the low to medium dose inhaled corticosteroids and long-acting bronchodilators. So in this study of GINA step 4 presented by Roland Buell at the European Respiratory Society meeting, we looked at the results in regards to medium dose inhaled steroids and high dose inhaled steroids, both combined with long-acting bronchodilator, and a large study, 45,000 patients. Now, of that study, there was a subset of patients that did not achieve control. These were uncontrolled patients, and that was about 18,000 patients. And what we found in this study was that they were more likely to be older patients, a current or former smoker, and to have had one or more asthma exacerbations in the previous time period than those that were controlled. Now, a significant percentage of these patients remain prone to exacerbation even when they're adherent to medium dose or high dose inhaled corticosteroid therapy plus a LABA. And this really, I think, indicates to me that these patients are not steroid responsive. In other words, increasing the dose of that inhaled steroid doesn't really achieve the response in a subset of patients that you would want it to. And that really indicates to me that perhaps a different approach needs to be taken in this subset of patients, such as add-on of a biologic therapy. It also indicates to me that it's important to regularly assess our patient's level of asthma control, and that we need to adjust treatment based on that assessment of asthma control. We also need to assess adherence, and that's an important component of our reassessment of the patient population. Now, as noted in this study, treatment step-up does not seem to occur for a significant proportion of these patients that were uncontrolled. And again, indicates to me that we really need to measure control in our patient population, and we need to adjust therapy based on that. Now, as demonstrated in this study, in GINA Step 4 patients, when you're thinking about an add-on controller, this study demonstrated that the preferred add-on controller was a long-acting muscarinic or a long-acting leukotriene receptor antagonist. And that was the preferred strategy for the vast majority of physicians that we noted in this study. And that was over titrating up the inhaled steroid dose or placing that patient on chronic oral corticosteroid therapy. And certainly that mimics my clinical practice, is that I prefer to add on a different class of therapy to these patients on medium to high dose inhaled steroids before resorting to increasing the dose of the inhaled steroid, or before, even worse, placing that patient on chronic oral corticosteroids because of the unacceptable side effect profile from chronic oral corticosteroids. Now let's review the results for the high-dose inhaled corticosteroid long-acting bronchodilator cohort of 16,575 patients that were presented at this study by Roland Buell at the ERS. In that cohort that were treated with high-dose inhaled corticosteroids plus a LABA, 45% of these patients remained uncontrolled during the follow-up. That's a pretty striking figure that despite on high-dose inhaled steroids and a long-acting bronchodilator, they still remained uncontrolled over that follow-up period. Now, of that larger group of those that are on high-dose inhaled steroids and long-acting bronchodilator, 26% of these patients of all the group, and then 32.6% of those patients that were adherent, stepped down their therapy. In other words, they achieved control with that high-dose inhaled steroid and LABA. Now, there was a subset of these patients, 22.9 of all patients, 36.8% of those patients that were adherent actually had to step up their therapy. In other words, they did not achieve control on this therapy. Now, among the adherent patients of this larger study, there were about 19,000 patients, which again reflects kind of our clinical experience that we know that a significant proportion of our patients are not adherent. Now, of that group, approximately 41% of these patients that were on that medium dose inhaled corticosteroid, and 31% of those patients on the high dose inhaled corticosteroid, again, both with a long-acting bronchodilator, a LABA, had no treatment step up at all. Now, this highlights really the need for regular reassessment of asthma control and treatment adjustment. And certainly in the GINA guidelines, you may recall that cycle, that circle, where you need to start your therapy, you need to assess the patient response, and you need to adjust the therapy. And this study, as presented by Roland Buell, certainly supports that reassessment that we need to do clinically in our patients. So in conclusion, this study highlights the importance of looking at those step 4 patients on medium and high dose inhaled corticosteroid with a LABA. And what was noted in this study also was that there was a subset of patients that were more likely to lose control in the subsequent year. And these patients were the ones that were older, those that were currently smoking or had been a former smoker, or had a previous exacerbation in the year prior. And so this indicates, again, some of the key things that we know clinically is that prior asthma exacerbations are a predictor of future exacerbations. We know that a significant proportion of these patients remain prone to exacerbation even when they're adherent to this therapy with medium dose or high dose inhaled corticosteroid. And this really, I think, indicates to me that these patients are not really responding to the inhaled corticosteroid component that is part of this therapy. And certainly indicates perhaps that a different approach in this phenotype of corticosteroid non-responding patients needs to be considered. I think this study also highlights really the need for regular assessment of asthma control, assessment of adherence, and really adjusting that therapy for your patients. We also note that treatment step-up does not seem to occur for a significant proportion of the patients. It was around 45%. And so one wonders, if these patients are uncontrolled and it's being assessed, why didn't the clinicians really escalate their therapy at that point? Now, when we look at these results in regards to the GINA Step 4 patients, we found that add-on controller therapy with a patient that was on medium to high dose inhaled steroid plus a LABA, that the preferred add-on controller was adding on a LAMA, a muscarinic antagonist, or adding on a leukotriene receptor antagonist. And this was the preferred strategy by the clinicians that were noted in this study. And that was preferred to increasing the dose of ICS or starting that patient on chronic oral corticosteroids. And clinically, I agree 100% with that, and that we know that the dose response to inhaled corticosteroids is not very good when you go from, say, a medium dose to a high dose inhaled corticosteroid. And we know that when you place a patient on corticosteroids, that really has a lot of side effects associated with this. So I agree with this study presented by Roland in that it really highlights that add-on therapy with a different class of an agent, such as a LAMA agent or a leukotriene receptor antagonist, would be my preferred route for approach to management of these patients when they're not controlled. So let's move on to another exciting study that was presented at ERS. This study was called the BORA study. This was a phase 3 edition of a anti-IL-5 receptor blocker called Benralizumab. Now, Benralizumab has been studied in a series of phase 3 studies called SIROCCO and CLIMA. And in the BORA study, what they did was they continued those patients that participated in those studies, the SIROCCO or CLIMA, they extended them into an open label extension trial. And that's what was presented recently at ERS by Bill Bussey and colleagues. So in the BORA study, this was a large study of 1,926 patients across over 400 centers in 24 countries. And in this study, patients received Benralizumab at 30 milligrams every 4 weeks or every 8 weeks, depending upon what they received in the original trial. Now, if they received 30 milligrams every 4 weeks in the extension phase, they continued that every 4 weeks. If they were receiving it every 8 weeks, they continued that every 8 weeks treatment. However, if they were in the placebo group and either in SIROCCO and CLIMA, when they were entered into the BORA study, they were then randomized to either one of those therapies. So 30 milligrams every 4 weeks or 30 milligrams every 8 weeks. So we're going to review the results from this 1-year extension study in these patients that received open label Benralizumab that had continued after they finished the original trial, SIROCCO and CLIMA, for that year-long regimen. And this is an important trial because what it does is it allows us really to understand long-term safety and with a new therapy such as demonstrated here with Benralizumab, an anti-IL-5 receptor blocker. So let's talk about the results that were presented at the European Respiratory Society by Dr. Bussey in regards to the BORA study. And what we found in this open label extension was that 74% of patients, basically 3 out of 4 patients that had elevated blood eosinophil levels at baseline, who continued on the Benralizumab every 8 weeks were exacerbation-free in that second year of follow-up on open-label treatment. And clinically, that's important. So when I'm starting a patient on a new therapy like this, Benralizumab, I'm needing to explain to them the importance of that therapy. Why do they need to come, for those injections? And the BORA study really provides that information, in that by starting and continuing on this therapy, 3 out of 4 patients were able to avoid an exacerbation. And that's an important information to convey to your patients, because these are patients that often have been on oral steroids before. And in fact, in the Sirocco and Klima study, they had about 2.5 to 3 exacerbations in the year prior. So now you're going down to a point where only 3 out of 4 patients had no exacerbations at all. So that's the importance of being compliant with this injection. As noted in both Sirocco and Klima, there is also not only improvement in exacerbations, but also an improvement in lung function and asthma control. And these were maintained in the BORA study. And that's an important point. I'm often asked by other physicians is, well, what do we know about over time? Is there tachyphylaxis in response to Benralizumab? Well, the BORA study demonstrated nicely that, in fact, there was not a tachyphylaxis that occurred. The benefit that we saw in the improvement in lung function and the reduction in exacerbations was maintained out over time. Furthermore, an important take-home message from the BORA study was, well, what about long-term safety, Dr. Castro? And what we found, and what Dr. Bussey presented at ERS, was that the same reported characteristics in terms of safety and tolerability that was seen in Sirocco and Klima were also noted in the BORA study. And in fact, we did not see any new side effects emerge. We did not see anything new that emerged over this extended period of treatment, now over 2 years. So I think that, again, that's something reassuring for us as clinicians when we're thinking about new therapies. We need to be able to talk to our patients about the safety profile and what's been observed. And so BORA really provides now that data regards to safety now over a 2-year period of time. So recently approved was a new monoclonal antibody called Dupilumab. Now, Dupilumab is a fully humanized monoclonal antibody that blocks the IL-4 alpha receptor. Now, the IL-4 alpha receptor is unique because it's both in the IL-4 and the IL-13 signaling pathways. So these 2 key T2 inflammatory cytokines can actually be blocked by this one monoclonal antibody, Dupilumab. So let's next talk about the Liberty Asthma Quest study. This is a phase 3 study that evaluated Dupilumab at the 200 milligram dose or the 300 milligram dose every 2 weeks. And they compared this to a matching placebo. The amount in each one of these injections were slightly different, so they had matching placebos for the 200 and they had a matching placebo for the 300 milligrams. Now, what was evaluated in the study, the primary endpoint was improvement in exacerbation rates, and this was reflected by the annualized severe exacerbation rate, and improvement in the FEV1 pre-bronchodilator. Those were the primary endpoints in the Quest study. In addition, they measured a number of secondary endpoints looking at change in lung function, improvement in asthma symptoms, and quality of life. So presented at the European Respiratory Society meeting was a sub-study from the Quest study. And this focused on an important patient subgroup, which is those that have chronic rhinosinusitis and nasopolyposis, or those without chronic rhinosinusitis and nasopolyposis. And this is a phenotype. This is very important that clinically we can recognize, because we know that these patients have a T2 phenotype. They have a increased expression of type 2 cytokines. We also know that these patients have significant comorbidity, and they're at significant risk for future asthma exacerbations, loss of asthma control, and poor quality of life. So again, clinically identifying these patients in your practice is important. And what was presented at ERS was that Dupilumab significantly improved patient-reported outcomes. So these are health-related quality of life, asthma control. that was measured by standardized instruments such as the AQLQ and the ACQ-5. Now, the improvements that were noted in quality of life and in asthma control, importantly, were observed as early as week 12 in this study and were maintained out to weeks 24, 36, and 52. So the entire year-long study, the improvement that we noted in these patient-reported outcomes was greater in those that had chronic rhinosinusitis and nasal polyposis than in those without chronic rhinosinusitis and nasal polyposis. Now let's talk about another poster that was presented by Dr. Bill Bussey at ERS. And again, this was a sub-study that was from the QUEST study with Dupilumab. This was a pre-specified analysis looking at those patients that had measurement of the sinonasal outcome test, appropriately called SNOT-22. And the sinonasal outcome test really helps us measure quality of life related to chronic rhinosinusitis. And so this is important when you're thinking about this group that really has heightened comorbidity, heightened risk for future exacerbations. What impact is it having not just on their asthma control like we just discussed, but what impact is it having on their chronic rhinosinusitis? Now, as reflected in the SNOT-22 in this sub-study, both doses of Dupilumab, both the 200 milligram dose and the 300 milligram dose, significantly improved the SNOT-22 scores when compared to placebo at week 12, 24, and 52. So again, this indicates to me that the change that we're seeing in chronic rhinosinusitis symptoms in these patients occur early on with treatment with Dupilumab and is maintained over this year-long study. And the magnitude of changes that we're seeing with the SNOT-22 was beyond what is reported as the minimally important clinical difference. So again, these are important changes that occurred in response to Dupilumab in regards to their chronic rhinosinusitis symptoms. Important information for us to take back to our patients. Now, another poster that was presented at ERS was regards to those patients that have chronic rhinosinusitis and nasal polyposis, what happened to their exacerbation rate over this year-long study. And what was presented at ERS was that Dupilumab, when compared to placebo, significantly reduced asthma exacerbations by 63% if they were on that 200 milligram dose, and by 61% if they were on that 300 milligram dose, in those patients that had that phenotype, the chronic rhinosinusitis nasal polyposis phenotype. In comparison to those that did not have that chronic rhinosinusitis nasal polyposis history, the reduction in exacerbations was 42% with the 200 milligram dose and 40% with the 300 milligram dose. So what was presented in this poster at ERS was looking again at the effect of Dupilumab, which is this IL-4 receptor blocker, on the biomarkers. And this is important clinically because what we need is biomarkers really to help us in asthma management. What was demonstrated in this poster was that Dupilumab at the 200 milligram dose and the 300 milligram dose given every 2 weeks produced a rapid and sustained suppression of FeNO, the expired nitric oxide, and the measurement in the plasma in the blood of type 2 inflammatory biomarkers looking at IgE, eotaxin 3, periostin, and TARC. So these were the 4 different type 2 inflammatory biomarkers that were measured and demonstrated with both doses of Dupilumab 200 milligrams and 300 milligrams that there was a rapid reduction in the biomarkers, and that this was also correlated with the reduction in severe exacerbations and improvement in FEV1 in the patients that participated in the QUEST study. Now, there's another piece of important information that was obtained from this biomarker sub-study. And one of the things that was noted in both QUEST and in the VENTURE studies was that there was a transient increase in blood eosinophil counts in a subset of patients. And in this subset of patients, where clinicians are wondering, what does this blood eosinophilia mean? And what was noted in this biomarker study was that there was this nice correlation with decline in eotaxin in that as a biomarker with the rise in the blood eosinophil levels. And this occurred early on in this year-long study. And so our hypothesis is really that Dupilumab is blocking the migration of those eosinophils into the tissue, and that's by decreasing eotaxin, but does not block the production of eosinophils from the bone marrow. And this makes sense because the IL-4 receptor is not going to have an effect on eosinophil progenitors that are in the bone marrow that are producing the eosinophils. And so in essence, the eosinophils are trapped in that vascular space. Now, as demonstrated in these sub-studies, Dupilumab was generally well tolerated. The most common adverse event that was seen in the Dupilumab groups were viral upper respiratory tract infections, injection sites reactions such as erythema around that injection site, and bronchitis. Now, in addition at ERS, there was a post hoc analysis of the VENTURE study with Dupilumab. And importantly, the main difference between VENTURE as opposed to the QUEST study that we talked about, VENTURE focused on that subset of patients, difficult to control patients that are on chronic oral corticosteroids. Now, Dr. Klaus Rabe presented this post hoc analysis of the VENTURE study looking at the effect of Dupilumab on type 2 inflammatory biomarkers in this subset of patients that are dependent on chronic oral corticosteroids. And again, this is important because we need these biomarkers to help understand how to manage these patients and how to select these patients for biologic therapy, such as with Dupilumab. Now, what was presented at ERS was that when you used add-on therapy with Dupilumab at 300 milligrams every 2 weeks compared to placebo, this significantly reduced expression of exhaled nitric oxide, or FeNO, in the airway, and reduced expression in the plasma of eotaxin-3, in the serum of periostin, and of TARC in the serum. And this occurred very quickly at the onset of that trial and was sustained over a 24-week period of time. Now, key difference again is that compared to QUEST, VENTURE was a shorter-term study, 24 weeks, and was focused on this subset of patients on chronic oral corticosteroids. And in VENTURE, the only dose that was evaluated was the 300 milligram dose of Dupilumab every 2 weeks. Now, what was interesting in this sub-study of the biomarkers in the VENTURE study was that we saw a gradual decline in serum total Ig over time, as opposed to that rapid decline that was seen in those other biomarkers such as FeNO, eotaxin, and periostin and TARC. So Ig was much more gradual in terms of its decline over the time period of treatment over this 24 weeks. Now, we did note, again, in VENTURE study, an increase in the blood eosinophil levels. And this increase, again, was near the beginning of the treatment. It was a transient increase. It was not sustained over a period of time. And we, again, believe that this transient eosinophilia that we see with the initial treatment with Dupilumab reflects a mechanism of action due to the blockage of Dupilumab on the IL-4 receptor, where it's causing a decline in eotaxin, which is a key chemokine, which is important in migration of eosinophils to the tissues. But Dupilumab is not blocking the eosinophil production. It's not blocking the effect on those eosinophil progenitors in the bone marrow. Therefore, in essence, those eosinophils are kind of trapped in that vascular space, and that's why we're seeing a transient eosinophilia in response to Dupilumab in that initial treatment. And it makes sense, again, that you start to see a tapering of that effect over time as you see the reduction in those type 2 biomarkers. Now, in that subset of patients with that transient eosinophilia, we did not know any increase in clinical adverse events or consequences from that eosinophilia. Now, Fevipiprant is also known as QAW039, and it's an oral drug that actually inhibits the DPP2 receptor. This is an important receptor on prostaglandin D2. We know that the prostaglandin D2 is actually produced by mast cells that are activated once allergen encounters antigen-presenting cells and triggers downstream events to activate those mast cells. And therefore, inhibiting prostaglandin D2 with a DP2 receptor antagonist would be an important advancement. Now let's talk about a study that was presented by Chen and colleagues at the European Respiratory Society in regards to the potential mechanism of action of Fevipiprant on the variety of ILC2 activation pathways. Now, we found in the study by Chen and colleagues that inhibition of this pathway with Fevipiprant inhibited DP2-mediated ILC2 migration. It inhibited the effect of prostaglandin D2 on the ILC2 cells, the innate lymphoid cell 2 cells that were undergoing apoptosis. So it reversed that effect on ILC2 apoptosis. Furthermore, it inhibited cellular aggregation and prostaglandin D2 mediated effects, and it also inhibited the production of type 2 cytokines from the ILC2 cells. Again, these are important type 2 cytokines. IL-4, 5, and 13 are the type 2 cytokines, and we know that ILC2 cells produce IL-5 and IL-13. So blocking this pathway through the DP2 receptor is key in terms of the underlying pathophysiology of asthma. So this data that presents in regards to the ILC2 mechanism that Fevipiprant may be acting upon helps us understand its potential mechanism of action. It really supports its future development as a treatment for asthma. Now let's talk about the final study that we'll be presenting from the European Respiratory Society. And this was presented by Bill Bussey and colleagues. And it was a phase 3 study called TROPOS. Now TROPOS was evaluating the oral steroid-sparing effect of an anti-IL-13 drug called Tralokinumab. And this was, again, evaluated in patients with chronic oral steroid-dependent severe uncontrolled asthma. Now the TROPOS study randomized 140 patients to Tralokinumab or placebo, so there were 70 patients in each of the arm. And in that study, 129 patients completed the study and 124 patients completed the treatment. Now at week 40, the percent reduction in the oral steroid dose was not statistically significant in those patients that received Tralokinumab when compared to placebo. It was 37.6% versus 29.8%. And this was not a statistically significant difference. Furthermore, in the TROPOS study that was presented at the ERS, there was no significant difference between those patients that received Tralokinumab or placebo in any of the secondary endpoints. These secondary endpoints included the proportion of patients that were able to reduce their dose of oral steroids down to less than 5 milligrams per day, the proportion of patients that achieved a 50% or greater reduction in their oral corticosteroid, and asthma exacerbations. So all these secondary endpoints also were not met. So many of these studies that we've just presented from the European Respiratory Society have presented long-term data in regards to both efficacy and safety of these treatments for our patients with severe uncontrolled asthma. Now, some of these treatments are already approved that we covered, and some are still being studied as potential investigational agents. But in the future, it's very promising that these will emerge as new biologic agents. Now, I think it's an exciting time because with these biomarkers that we discussed today that were presented at the European Respiratory Society, it allows us to really think about how we could use that in the management of our patients. So the idea with these biomarkers is we're going to identify that subset of patients, and then we're going to be able to reach to our toolbox and really pick the right biologic agent for that patient. And as presented here, that's truly highly effective therapy with really an acceptable side effect profile. So I'm really excited as a clinician managing these patients. I kind of think about us as rheumatologists were about 15 years ago when they were managing their rheumatoid arthritis patients with methotrexate and chronic steroids. And really, when you think about their management of that chronic disease, they've really evolved to the use of these biologics. So I think as an asthma specialist, we're really going to need to be comfortable with these biologic agents. And this data that we just presented from the European Respiratory Society, I think really adds to that evidence base that we need to help us reach that stage of personalized medical therapy for our patients with severe uncontrolled asthma.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/GGG. This activity is supported by educational grants from Novartis Pharmaceuticals Corporation and Sanofi Genzyme and Regeneron Pharmaceuticals. This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education.